Good morning and a very warm welcome to Bonitas house called here on SABC2. Mabanda kamjokwana kandaba nina bakaMalandela. Zulu mnyama ndlela simhlophe sikhulekile ekhaya. I'm Dr Victor Ramathesele. Inani ngilungisitsa nakakadlungu. Oluzokubona njalo ngomgqibelo maseligamenxe elesishiyagalombili ihora ekuseni. Now the problem with most of health products and services is that the end user, the patient, is not the one who makes the choice and the final decision. The doctor does. And a few where they do, it is often inadequate or inaccurate information that is given to them to make a choice. And sometimes there are not sufficient checks and balances to protect the patient. And that is the subject of today's discussions, health advertising. Now we've invited into the studio Dr. Trevor Majoro, who's an independent medical practitioner. We've also invited Dr. Charles Lamula, or Mr. Charles Lamula, Acting General Manager, Professional Boards in the Healthcare Professions Council of South Africa. And to complete the trio, we also have Dr. Howard Mayonga, who's a risk management consultant. Hey, Bafit. Today it's all boys, no ladies, no woman, no cry.
Yeah. No.
Having a very, very interesting discussion. And colleagues, I'm very, very happy that today we are all here because we want to talk about a very, very critical subject. And I said in the introduction that the problem with healthcare services, Dr. Majoro, is that the final decision is not made by the patient. And therefore, all manner of advertising and detailing by makers of various medical interventions, whether it is a scan, whether it is a medication and whatever, they are all made to the doctor. And the patient doesn't make the final decision. Do you think that is a problem necessarily?
It is a problem. I think we've inherited it from the past. People have this notion that, this doctor complex kind of thing, thinking that the doctor has got the final word on everything. But remember, this is borne by the fact that they have the trust. They know that these people have been trained to look after us. The problem is when people using the same labels want to practice when they don't have the same knowledge and accountability. I think that's where the problem comes in.
Now, you come from the Healthcare Professions Council and you are here to give us advice.
Yes.
Now, can you say in a blanket response, are doctors allowed to advertise themselves?
Dr. Ramathesele, doctors are allowed to advertise themselves. In the past 15 years or so, doctors were not allowed. They could at all.
They were not allowed.
They could do so only on a nameplate, right? But the challenge we have these days is you have doctors that would advertise unprofessionally, unethically, and in a deceitful manner, in a manner that would otherwise deceive members of the public. I'll give you an example. You have a physiotherapist that would indicate ngaka ya marapo. It's grossly misleading because ngaka ya marapo is an orthopedic surgeon. Udokotela wemahlo. It's an optometrist, right?
Now, optometrist saying udokotela wamehlo.
Yes.
Engana MBCHB necessarily.
Yes. But you see, an optometrist, the problem is an optometrist is not a doctor. That's where the fundamental problem is.
But where are the rules written? As a doctor, yes, you are allowed to advertise, but these are the parameters within which you must advertise. Where are these things written?
We have ethical rules in our ethical rulings, which state every practitioner is allowed to advertise, but within the parameters of our ethical rulings. In other words,
and what are those parameters?
Parameters, Dr. Ramathesele, in summary, it's simple. It's simply that you cannot advertise in a manner that is unprofessional, in a manner that induces shock in consumers, right? In a manner that is untruthful.
Hold on. This is an advert that I picked up in one of the daily newspapers. Where is it quickly? Where's the advert? Good. Now there it is. This I picked up in an ordinary newspaper, one of the daily newspapers that here. Yes. Is this allowed? A doctor advertising said, government approved for safe abortion for 4 weeks, up to 20 weeks, special cases, giving the address opposite some filling station somewhere. Is this okay? You can remove it. Is this allowed?
Dr. Ramathesele, firstly, the doctor is a practicing doctor,
yes,
right? But what I find fundamentally incorrect is, in terms of the Termination of Pregnancy Act, you can.
Let's leave the Termination of Pregnancy Act. But would a doctor be allowed to go into a daily newspaper and say, here's my name, this is where I am, And this is what I've done. And the size of the advert, is that in keeping with the rules that you have set?
The fundamental problem as Health Professions Council that we have is that you cannot claim prominence over other practitioners, right?
Yeah. But if you're prepared to pay for it, he must have paid for that ad.
He has indeed. But it's somewhat misleading in my view, right? Because it says it's like, let me give another example. You have a doctor that would otherwise advertise and say, here practice is the best doctor that ever lived or that ever stayed in this town. That is grossly misleading. And as a doctor, when you advertise, you cannot say, I'm a specialist in something.
If you are?
As a general practitioner.
Oh, as a general practitioner, we understand.
You cannot.
But before I go to Dr. Mayonga, because now he's here to represent the patient themselves.
Yeah,
I mean, that's what he does for a living. But before we do that, were it not for the abortion issues, which we'll discuss a little bit later, is that practitioner allowed to advertise the manner in which they've advertised, where they are next to a filling station somewhere, their operating hours, and they've bought space in a daily newspaper? Is that allowed or not?
I say it's not allowed.
Okay.
Before I step off the issue, Dr. Ramathesele, for me, it's for example, it's like printing pamphlets and distributing them in a maternity ward and say, I do abortions. That would be wrong.
Now, we'll come to abortions because that's another hot subject. Dr. Mayong, what do you do for a living? You're a trained obstetrician and gynecologist.
I am indeed a trained obstetrician and gynecologist, and I'm also a risk management consultant in healthcare, working in the area of patient safety, and but I'm also a head of women's health at the VITS Reproductive Health and HIV Institute.
Lots of work. I don't know where you find the time, but the late Dr. Montana said, if you want to have anything done, give it to a busy person. Bless his soul.
Absolutely.
I always remember those words coming from the doyen of general practitioners in Soweto, and a very prominent community member who has since passed on. But now, now as somebody who's concerned about doctors and litigation issues that doctors have to undergo, but at the same time, who's also interested in protecting the well-being of the patients, what is your view around the level to which patients are bombarded with information and sometimes misleading information?
Yes, I think the difficult thing for our patients is that they cannot evaluate the claims made by doctors. And this is where my colleagues from the HPCSA come in with the ethical rules which guide the profession. However, they're not always successful, as witnessed with some of the touting and canvassing that we see on the streets. I mean, I have an office in Hillbrow where we see at the street corners pamphlets advertising abortions and so on and so forth. And patients aren't always able to evaluate the veracity of...
Let's cut to the chase.
Yes.
Are the authorities, Healthcare Professions Council of South Africa, and anybody else, including the SABC, if that is the case, are they doing enough to protect patients?
Look, the HPCSA has got excellent ethical guidelines. So there's a series of books on ethics, booklet 1 to about 15 or 16, I may say to be correct, to 16, which gives the profession the guidelines within which they can advertise.
But can they follow those things up? Can they ensure that members of the profession adhere to those rules? My
own personal view is that they could do a lot more. I think there's a lot of gaps, particularly in enforcing some of the ethical guidelines. And in a way, the HPCSA is perhaps very reactive. That, I mean, I'm happy now that they've appointed an ombudsman, which is a step in the right direction. But as of now, there has been a lot of reactive, knee-jerk reactions rather than being proactive in going out, doing the road shows, which they do, but perhaps not nearly enough. Because in my work, I do a lot of workshops for doctors in far-flung places through the Medical Protection Society. And our experience is that the doctors out there, the young doctors especially, need a lot of guidance. And they're not necessarily getting good role models. And you've got a bad father, you turn out to have a bad son. And doctors...
The apple finally fell. No, but hang on. Before we come back to that, Dr. Mayong, with the introduction of the new Medical Schemes Act, and also the introduction of the Medicines and Related Substances Amendment Act, I mean, truly, we have seen the life of the typical general practitioner being squeezed, and a lot of doctors not making as much money as they used to from general practice in a general sense. And there's a view that this, to some extent, could have led to a certain measure of desperation among colleagues and who might have wanted to advertise their services a little bit more, to see more patients, and therefore to maintain a certain standard of living. Would you agree with that?
Yes,
Doctors have been under pressure somewhat?
I think it has contributed. Firstly, if you look at life in general, if you lose your sense of purpose, it's a problem. Because in the beginning, as you know, in the past, not everybody went into the profession for the same reason. Some say it's a calling, for some it's something else. But purpose is important because, like as one person said, I think it was Dr. Miles Monroe, he said, where purpose is not known, abuse is inevitable. In other words, you can misuse something that is meant for something else. So in this case, if somebody is trained to be a medical doctor and their purpose is solely exactly to ensure that the well-being of a human being is upheld, it doesn't matter what pressures come. People will not stray away from the rules. But like you said, some people have seen it as a money printing industry. And unfortunately, the old days of the medical aid schemes where, we would charge whatever script, knowing that you dispense your medication, you are paid, nobody argues anything. Everything now has
Things
been
have
squeezed.
changed.
There's managed care, everybody's trying to cut the cost. So those things are not happening anymore. So what do people do now? They've got options. One of them is to enhance their sense of self-worth in the practice, like my colleague was saying, meaning that they claim prominence when actually they are probably doing something even inferior to what somebody else could actually be doing better.
And the poor patient is the one who suffers in the end.
Does not know. The patient just sees that this is a doctor. It means this person has been trained to help. So patients believe. But I would like also to say that it's about time that we educate our patients, we arm them, because if they've got knowledge, that's the one thing that will save them from a lot of troubles.
That's what we hope to do. That's what we hope to do today. Like they say, trust me, I'm a doctor. I've seen a car sticker that says that. I'm not sure if that is still applicable. And of course, we don't know whether the profession has gone to the dogs or the dogs have come to the profession. Now, we always say not all that glitters is gold. Man, let's hope that we are so to hire was a hat looking on a clothes. Mitzi, immediately go fly. We'll continue our discussion on health advertising. Guys, madume ga fele gompieno re tla lo seka matsepa a ba borogile ba rekisi ba ditirelo tsa merero ya boitekanelo gore botsogo mo Africa Borwa. Now, health advertising is a matter that vexes users, providers, regulators, and policymakers alike. And the media is often accused of being inconsiderate of the sometimes gullible public. Let's see this particular advert that I want my colleagues and I here to focus ourselves a little bit on. Now, colleagues, I picked this up from an adult daily. Now, this is one page. Abortion for 100 rand, abortion free cleaning and screening from 150, abortion pills that you can get from 100, abortion SMA, abortion. Dr. Mayonga.
Look, this is quite distressing in many ways.
Is this allowed?
When I look at the ethical rules of the HPCSA, there's a guideline that is there that when you advertise, you must put your name, your practice number, where you're practicing from, your qualifications, and a few other details that would constitute an ethical advert. And I don't see any of those details there. And I would guess that a lot of those doctors are not real doctors, and they may not be registered at all. Or like we see in Hillbrow, people calling themselves with their first name, like Dr. Howard, or when it's supposed to Dr. Howard Manyonga, MBCHB, FCOG, or whatever. They just put Dr. Howard and a cell phone number. So that, in my view, that is falling foul of the HPCSA guidelines.
Now, I know of many, many women who, of course, when they need to have a termination of pregnancy, it is usually because they are extremely desperate.
Yes.
And because they are desperate, they are gullible and they want to any help. And because it's a cost issue also, they want to go to somebody who will provide the services for any reasonable amount that they'll be able to part with. And I am worried that when somebody reads this, they've not listened to this show, or they've not been informed, or they're even uneducated, there is absolutely no protection whatsoever. And these guys are not going to take any rep, they are not going to take any responsibility for anything that goes wrong. And we know that people who have gone for abortion, unless they are properly managed, they will die.
They can die, and in fact, abortion is offered for free in the public sector. And the Department of Health have done and are still doing a great deal of work advertising and educating patients, which comes back to my colleague's view that we have to educate our patients. So it's available for free in any public sector. Of course, you can have it in the private sector where you pay. But you certainly raise an important fact that if the abortion is not done safely, then there's a major risk to the patient, and a lot of patients die. And one of the reasons, which was the main motivator for the choice of Termination Act, was precisely because the academic institutions demonstrated quite eloquently that the mortality from unsafe abortions was unacceptably high. Unfortunately, a lot of our patients still opt to go for backstreet.
They go for
abortions.
backstreet because when they go to you guys in the public sector, you tell them it is too late, it is over 20 weeks. And somebody says, yes, we can do you
Over 20
even
weeks.
if it's over 20, when we all know that it is very, very unsafe to do so. Yeah. But the question that I'm asking, how do these adverts find their way into the newspapers?
Dr. Ramathesele, my take on this, it's perhaps as HPCSA we need to make an appeal to media houses, perhaps to
We
make...
tried to get them on board, by the way, for this show, and they wouldn't come through because we wanted to speak to the media houses and say, how do they get to do this? And what checks and balances do they have they put in place to ensure that the people that they advertise are legit?
Yes. So I was saying, perhaps we need to make an appeal to media houses to say to them, whatever advert they put in their papers, print or media, or otherwise, they should perhaps look into checking with us as HPCSA whether it's ethical. Because clearly this is not ethical. As Dr. Mayonga was pointing out, the name of the doctor has to appear and all the details, where this practitioner is, phone numbers and so on and so forth. But clearly this is unethical.
There's no protection for the consumer,
At all.
Dr. Majoro. There's absolutely no protection.
I think the other thing that we really need to consider, maybe from the Health Profession Council and government as well, is enforcement.
Yes.
Because the rules are there, you know. And if you look at all rules, it doesn't matter whether it's health or it's non-health. Even in the streets, there's a stop street, but somebody just passes and hit the other guy who's correct. Yes. So the matter of who's wrong and who's right needs to be enforced by law enforcers, because they are laws. So people like these, where we see these adverts, I think the law must just take its course. The media houses must be approached. These are the regulations. You should be advertising responsibly. What happened in this case? Because just that piece of paper, it has been proven. In fact, it's one of the very popular newspapers in the country. How many people have read that? And as you were saying, Dr. Vic, how many have gone out to those people to do a quick abortion?
Yes.
You know, as we were getting here, one lady was just telling us how her sister went to one of these doctors who said, you can have the abortion even at 24 weeks. And they gave her a tablet. All that tablet does, it helps the womb to expel whatever is there. But you will bleed. And she bled to death.
Dr. Ramathesele, just to piggyback on what Dr. Majoro has said, sometime last year, in the early part of last year, I had to prosecute a case where a registered medical doctor, our own member, terminated pregnancy at 36 weeks. 36 weeks.
That's murder.
And did so in a very violent manner. There's something that he inserted vaginally, dismembered the fetus in utero, right? And at the same time ruptured the uterus, left products of conception inside, and as we speak, the patient has passed on, right? So it's not like backstreet abortion per se. Even our own members flout the law, Choice on Termination Act.
Do you have a view, Dr. Mayonga, that sometimes general practitioners might overstep the mark and begin to perform procedures that they are not necessarily qualified to do? Because I know of a lot of practitioners, general practitioners, who can do a cesarean section very well. I know of a lot of general practitioners who can do a tonsillectomy very well, and a few other procedures very well, because they spend a lot of time doing that in practice. But I do feel that there is no guideline. Anybody can wake up tomorrow and say, I can do a cesarean section, and the poor patient is not protected. Your view?
And that is the problem. And I think Dr. Majoro highlighted the financial pressures that in trying to extend the range of services that one can charge for, it is very tempting for doctors to go beyond the scope of their practice, or perhaps beyond the limit of their own capabilities. And for the patient, there's no way of knowing. I would go based on what the doctor claims to be able to do, and perhaps based on word of mouth from patients who have been there, but certainly that tendency of doctors practicing beyond the scope of their own competencies
But
is a major
sometimes
problem.
it's not greed. Sometimes I know a lot of colleagues who work in the far outlying areas where
Yes.
specialists are just not, available, and the guys are forced by circumstances to make an attempt,
Yes.
to perform some of these procedures.
This is where surveillance becomes very important, and we have learned from countries like Australia, where they've got doctors in the outback who are practicing isolated, okay? So you can put learning programs for doctors, but it has to be well managed. I mean, the HPCSA does have the continuing professional development programs, but the way that it is administered and run, I think there is a lot more that can be done. And this is where we have been lobbying and quietly to say, look, this is risk management. There is patient safety matters here, and let us come in and work and develop frameworks which we can pilot and roll out to see that patient safety is safeguarded. But also we protect our colleagues in the profession, because when we support them, we enable them to perhaps practice safely, and the whole stress of going to HPCSA and being prosecuted then falls out. And it's more satisfying if you're a professional working within that. But where we are lacking right now, our risk management systems are at best dismal or non-existent.
It would appear to me that the Healthcare Professions Council of South Africa has relied for too long on the integrity of the doctors. For too long, it has relied on the ethics of the doctors, and that the doctors can self-regulate, that they can appeal, to the integrity, that you cannot do X. But in the end, I'm sure we are ready to admit that the organization is toothless, and we have not been able to deal with this matter as a collective. It may have worked 20 years ago, but possibly the doctor of 2014 needs to be treated a little bit differently, and possibly with a little bit more custom.
Dr. Ramathesele, that's why at every forum that we get to address, we appeal to members, registered members, to familiarize themselves with the ethical rules of council, to every now and then check on the website what is the new development, attend CPD, to their CPD, so that they can learn how to do new things. Medicine itself evolves, right? For example, in our ethical rules, we have ethical rule 21 that says our registered members may not do a procedure for which they are not sufficiently trained.
But they do.
But they do.
So it cannot be a matter of ethics. It has to be a matter of rules and laws that are enforced and that are punishable.
Unfortunately, like our police services, you can't arrest a person before that person commits a crime. So our approach is reactive, but to an extent we can, humanly possible. We've been across the whole country on roadshows. We get to present at symposiums and so on and so. Various provincial outfits, Department of Health, they'll call us in to say, come and address our people on ethics. We try our best we can, humanly possible, to talk to our registered
Dr.
members.
Majoro, what is your advice to patients? Do you say don't respond to any newspaper or radio or television advert insofar as health services are concerned? Would you say don't even bother? Or if you do, these are the things that you must check out?
The order of nature of a human being is to grow in society where there are institutions, like church, for example. So what happens is everybody in a community must have, for example, you must have your own attorney, if you can afford one, or at least legal aid or legal wise, whatever. You must have an institution that is reputable, that you are attached to. You must have a healthcare professional as well, that you can trust. That is why when things like this come up, that's the person you can go to, even if you are not sick. I hear my colleague here saying that just like the police, you can't arrest somebody when they've not done anything wrong. It's very true. There's another side to it, to say how do we prevent somebody from doing something wrong so that the police doesn't have to do a lot of work. In this case, how do we prevent such things from influencing people to make decisions without informed consent from them because they don't have sufficient knowledge? Have somebody that you trust in health, just like you do in law. attach yourself to that person, somebody you can walk to and say, today's consultation, I just want to know about this thing. And on the other side again, as healthcare professionals, we must open up to say, people can come to us for information. They must not only come when they are ill, because we can actually nip the problem in the bud when we give them the information that is going to assist them.
But Dr. Majoro, I have a problem. Just before we go to the end break, a lot of these adverts will find themselves in the type of newspapers that I will read for you when you come back after the break. When you return, we'll continue our discussion on health advertising. Stay with us. Welcome back. You're watching Bonitas House Call here on SABC2, and today we are discussing health advertising. Now, I have a daily newspaper here, but for you, it says, "Khuthaza amasotsha omzimba, uhlanze umzimba wakho manje." Manje khuluma ngomuthi la ukuthi ukhuthaza amasotsha omzimba uvikela amagciwane asebuthini begazi ilwa nesifo se-TB, idambiso HIV. I mean, this is something that is in a daily newspaper. I mean, another one is here, you find constipation, indigestion, hangovers, headache, rheumatism, nausea, gout. Now, you can't have one medication doing all of this.
Yeah.
It can't be right. Now, this happens, this advert is in a newspaper that has got the highest readership and circulation in the country. And it is a newspaper that is typically directed towards the people of the lower LSM group, so living standard measurement, people who are fairly illiterate. Now, these are people who will rely on information that is provided them at this level. They don't have a lawyer, as Dr. Majoro suggests. They don't even know about the existence of the Healthcare Professions Council of South Africa. Dr. Mayonga, how do we protect? You can't have a medication that does all those things. It just can't be true.
Certainly, I mean, this is a typical example of quackery. People claiming to have medicines that are panaceas for everything.
Correct.
And this is probably somebody who's working outside of the formal profession that is regulated by the HPCSA.
But they find these adverts into the highest circulation newspapers.
Absolutely, and I think the media houses are probably just giving the space to anyone who can pay for it.
But they want to make money, they've got a profit motive.
Absolutely, so that is where perhaps the difficulty is, that the media has got its own freedoms to interact with people who come to them and who want to advertise if they can pay for it. And these people sometimes are outside of the regulatory framework of the Health Professions Council. And what I would hope that the Traditional Healers Regulatory Council would come into it, because there is such an organization, isn't there?
There is.
Yeah. So some of these people, perhaps we would need to go in quite systematically, knowing that our patients do not have the resources sometimes to retain a lawyer, or even the knowledge of what to do about it. But we, as the profession and the regulators and government, have to develop the frameworks to protect the most vulnerable people in our society. And sick people are vulnerable, and in their desperation, they will do whatever they think is gonna bring some relief. So I would still go on to say, having a proactive mechanism where we go and say, look, from a risk management point of view, these are the things that we need to be in place. And we can learn from other countries. We are not the only country facing this kind of problem. So there are very good patient advocacy movements overseas. I mean, I've just recently been going through a report from a center called the Center for Professional and Patient Advocacy, which brings together...
Which country is this?
This is from the US, which brings together input from patients. They track patients' complaints, patients' outcomes, and bring it into a reporting system that can profile doctors, for instance. Yeah? And there, perhaps Bonitas and other medical aids, because they sit with this data, which we can go and mine. We can see trends. I mean, if a doctor is practicing outside of the norm for the average colleague, medical aids can track it.
Should we ban health advertising at this point, now that we all admit we've failed dismally as professions, we've failed dismally as regulators, we've failed dismally as patient advocacy groups to deal with this matter?
Dr. Ramathesele, I don't quite agree with you that as a regulator we have failed. But at the same time, advertisement is a right, right? But you see,
How do you define advertisement, by the way?
advertisement it's a very broad and wide industry. I think books and articles are written, others would write theses about the issue and so on and so on. But for our purposes, I think we define advertisement as a means by which a registered member of the Health Professions Council makes a consumer aware of his services and or product, right? Coming back to the advert that was just flighted here, Dr. Ramathesele, Ethical Rule 23, 1 and 2 of our ethical rules provides that, for example, practitioners may not be involved in the manufacture and or sale and or promotion of any medicine, right? Provided, unless they are in the employ of some pharmaceutical company.
And they are not practicing necessarily.
Yes.
And therefore they are not prescribing
Yes.
something
Indeed.
or a product in which they have a vested interest in.
Indeed.
So therefore their independence is compromised.
That's right.
But the same reasons, would you say it is correct, the practice that we see sometimes, a big hospital group setting an empowerment stake, and within that empowerment stake, they get a group of doctors, general practitioners and specialists to buy and own a stake in a hospital group? Because obviously, if I'm a doctor and I have shares in a hospital group, I will refer my patients to that
Yeah.
for admissions, for investigations to that particular.
Yeah.
Would you say this should be outlawed?
This is a,
Does it happen? Let's start there.
Yeah.
You agree it happens?
yes.
Yeah. And you agree that it biases the patient because the doctors will make decisions that are in their favor and not maybe in the patient's best interest?
Definitely. It's actually a tricky one because, number one, if I'm a practicing medical doctor and I know that I've got shares in a particular hospital, surely I'll want people to be referred there because that's my future investment, if you like. But the problem here comes in where even when there's no need to admit somebody, as you know that most of the money is made from sleeping in the hospital than actually getting the treatment,
Yeah.
So
the hotel services, as we
so,
sometimes
yeah.
refer to. Yeah.
So now what happens is people end up being admitted even when they are not supposed to be admitted. And that's where the issue of need and greed comes in. Because there's no need for this person to go to and be admitted, but the greed says, we want some more. And medical aid will pay for that. So basically, I would personally discourage it and say maybe there should be a ruling where those doctors who buy a stake in a particular hospital don't practice within the vicinity where that hospital is. So it's just an independent investment that happens elsewhere, like they would buy shares
Why
far away from them.
do we allow doctors to own stakes in hospitals and in pharmaceutical companies and many other services that might be needed for the patients that they are responsible for?
Dr. Ramathesele, the practice is out there. What you'll have hospitals that are manned, for example, trauma and emergency unit, that are manned by a group of doctors. This matters before what we call undesirable business practice committee for consideration. A determination has not been made, but as Dr. Majoro points out, the impression that is created is the doctor have this unwritten expectation that the patients that are seen will surely be admitted because they've got a stake, they've got an interest, right? We are saying it's wrong. How does this come about? Ordinarily, there would be a number of doctors who individually have practice numbers. They would surrender their practice numbers. Then there will be a group practice number under which they practice. Another angle to it is when it comes to billing. If you're Dr. Ramathesele, you see a patient, right? And subsequently, the patient is billed, and there's query with regard to the bill. Now, who will be responsible for the bill, right? Because we have outsourced that one, because the billing comes now from the hospital, not from you as a medical practitioner.
I know.
Yes. So from a distance, we are saying it doesn't look right.
What are we doing, Dr. Mayonga, to improve patients' weight, patients' voice, patients' decision-making in this process, and maybe get to a point where I, as a patient, can decide that I'm going to be admitted at hospital X because it is closer to me or because of whatever reason, instead of allowing the doctor to make that decision? What are we doing to strengthen the decision-making and also the general weight of the patient in this whole equation, because this is a patient who gets the wrong end of the stick?
Unfortunately, the reasons behind the status quo are many. And from a patient's point of view, we know that as the level of education increases in society, patients become more assertive. That's the one thing. So there's that general trend. So rising levels of education will lead to more assertive patients. However, there is a lot more that can be done, and you have got centers like the Center for Applied Legal Studies at University of Witwatersrand, which takes up pretty much like class action on behalf of patient groups. You have got your people like Section 27, TAC, civil society, which is very active in educating patients. But where there is an opportunity is for the regulators themselves to then go and be advocates for patient safety. And they can work in tandem with organizations like the Medical Protection Society, some private consultants who have got an interest in making sure the discourse is right and patients are heard, and those who are not able to speak up for themselves, their voice is represented through advocacy. And we have a very strong culture of advocacy in South Africa, which we should be taking advantage of. Unfortunately, I think there's too many other balls to juggle for our regulators and our decision makers, but that is where we can partner with the regulators, government.
But we need the
and
media
other
to come to the
parties.
party, because
Absolutely.
without the media, you can't have
Yes,
advertising.
absolutely.
Therefore, if we are going to change anything in this perspective, one of the
Yes.
things that we need to do is to get the patient to be much more active, much
Yes.
more assertive. But certainly, we'll need the media to come to the party. We'll continue our discussion on health advertising after the break. Welcome back. Ngwaneso sa tswa pele ka hlosa letsatsi mona Bonitas house call or SABC 2. Ai ka jeno re tshwere taba tse thata nnete ke bala le ngwe mona, just one of the newspapers ekhuluma nayithi imbiza yempilo ibhande izinso amathumba ushukela izinyawo ukukhathala isikhumba esibi ukuncipha komzimba ivule inhliziyo. One medication is supposed to be doing all of these things. I mean, really. And the media are happy to take these advertisements and make money. And the profession here is supporting it, and the poor patient has to use these things. And when there are problems, there's absolutely no recourse for the patient in the final analysis. Now, the ombudsman
Yes.
that has been appointed by your organization, is that still Professor Ade?
Bade.
Yeah.
The Professor Bade is our first ombudsman.
Okay.
He was fairly sessional
All right.
because he still had a practice in Cape Town.
Yes.
But now we've got a full-time ombudsman,
Okay.
Dr. Munyanziwa Kwinda.
All right.
He assumed his responsibilities this month.
Oh, beautiful.
Yes.
So who's supposed to anybody who's got any problem, somebody who's gone to get abortion pills because they responded to an advert and they have problems, they can contact the ombudsman. The ombudsman can do something about it.
No. The process is that you lodge a complaint with Health Professions Council of South Africa.
Yeah.
The complaint itself comes to legal. Now, if the complaint we classify it as minor or trivial, or can amount to what we call miscommunication, it's minor in nature, then the file is referred to the ombudsman to mediate, right? So that it doesn't clog our system, because it's minor in nature. But if it's serious, it relates to misleading advertisement and so on and so forth, then it goes through what you call a professional conduct process. Right?
But if it's not a doctor, it is an advertising by a herbalist, or it is an advertising by some of the other practitioners who just pick up the title doctor from nowhere and use it. And how do you take those people to task?
Herbalist Dr. Ramathesele belong to what we call Allied Health Professions Council of South Africa. We only have jurisdiction over members that are registered with us, right? Now, if it's somebody that is not registered, it's a matter for the police. Right? What in that instance, what we do, we would come up, we'd post to an affidavit that states Dr. So-and-so is not a registered member, so he's not permitted to be practicing as a doctor. So that person can be criminally prosecuted.
Dr. Major, what is the way forward?
I'd like to pay my focus to the patient again, because in life, you are your own representative. You've got to represent yourself. You know, there can be people who can represent you, but you must represent yourself. Attach yourself, like I said, to institutions or people. Even in rural areas, there are clinics there. You know, you don't have to have a private doctor. You can have a clinic and build a relationship with the clinic staff or with the doctor or with the nurse. And also even in families, you know, let's make our families be ambassadors, especially heads, you know, whether you are male or female. Be an ambassador of health and other matters for your own children. And in this regard, I don't like to sound political, but it's a fact. When you look at what apartheid has done, especially for black people in this country, it has taken them back not only in terms of financial issues, issues of integrity and dignity, but most importantly, it has set back their mind. And that gap, it's going to take us lots of years to close. I have the opportunity to work with both, all sorts of colors of people. And I can tell you now that white people are far much more advanced in terms of knowing what medication they take, what it does, which is why
they don't advertise. They don't advertise these things in newspapers that are geared towards the higher LSMs.
So
Definitely not. So they're taking them to people who are educated.
So when you look at our people, that gap, because of what happened in the past, still exists. The type of education that we got, the families that were crippled because of this separatism that existed then. We see the fruits now. We cannot look away from those things. We need to go back. Restitution has got nothing to do with victims of warfare only at every level of the struggle. It must go back to socio-economic, and part of the social is the mindset. People's minds have been set so back that we need to start there. Let's go to rural areas. Let's take our time, see the families that are broken, educate people, have centers of excellence there. Take your, I mean, as my colleague is saying, that they're working with people in different areas. Let's go there. Let's identify areas where there's a need. Service delivery should not only be about toilets, should also be about knowledge. So all these must be taken as a package to the rural areas specifically, and then to the urban areas.
Dr. Mayonga, you work with colleagues, you work with doctors. In one part of your life, you're also trying to protect those who might have fallen foul of the law. You also work with the patient advocacy groups and whatever. In a general sense, you do accept that there is a problem. Health advertising in this country is just open out there. People are just advertising willy-nilly. There is no sense of regulation, and the poor patient in the final analysis is given health services and health products, the safety of which is not guaranteed, the efficacy of which is highly questionable, and they have to pay out their hard-earned money for all of this. What is the way forward?
Look, this is what in management speak could be referred to as a mess. It's a mess because there's so many interacting parts, and there is no easy Occam's razor which you can use to cut through this. So we would have to be quite systematic to first say, look, let's involve communities, let's involve the regulators, let's involve the decision makers in government, patient groups, and also what Dr. Majoro is talking about, to educate patients from the lowest level, understanding that the constraints to their being assertive are partly historical, partly quite contemporary in that they may not have access to information. So my own sense is that as a start, the regulators would have to take the lead, come together with those of us who are working in the area to say, look, let's go and learn how others
But
have
the
done.
regulators need resources to do all of these things. And as we know how the HPCSA is funded, there's very limited resources. They've got so many responsibilities that they have to deal with.
Absolutely.
So at some point, we need to do something a little bit more aggressive. Bandala kwethu, iyaxaka ngempela le ndaba yokukhangisa nokudayisela umphakathi amakhathakhatha amaningi okuthiwa aqinisa igazi, amanye kuthiwa ayandisa amasotsha omzimba, amanye kuthiwa ke ayathuthukisa ngobulili nenkonzo yasekamereni, abanye ke kuthiwa konke nje okufanele kwenziwe, kanti ukuphepha kwale mithi kusuke kungaqinisekanga ngendlela ekuthe. Siyathemba ukuthi nonke-ke nizokuza lokho, kodwa thina sihlezi la siyakushoma ngempela lokho. We'll round up our discussion on health advertising when we return. You're watching Bonitas House Call here on SABC 2, and welcome back. Mr. Lamola, I've left you for last. We've shown you adverts here, colleagues professing to do this and the other. So kutshengisa amakhathakhatha la ephephandabeni okuthiwa abanye wozifo zonke bapholisa zonke izinto. Sibonile nabanye abanye imitholampilo ekhangisa ngokuthi bona bayakwazi ukukhipha isibeletho njalo njalo. What are we going to do as a Healthcare Professionals Council of South Africa, who have been charged with the responsibility of ensuring that the final information that is given to the consumer is both accurate and safe. What are we going to do going forward?
Dr. Ramathesele, as a first port of call, I think we should appeal to media houses to check with us whether what they get to advertise in their papers is indeed in line with our ethical rules, right? And then we'd also urge members of the public to be a little wary of what they get to read in the papers. Check with their local doctors to verify if indeed this is permissible, if indeed this is safe for them to embark on, right? And then other than that, perhaps I should urge our registered members as well we realize complications arise, even the most ablest hands, right? But we would urge, on the 18th of September, for example, 1997, our country gave birth to a bundle of joy called Watupili, keeping people first. It brought a lot of hope in the entire republic that for once people who have been in public institutions have been treated with disdain and disrespect would for the first time be given VIP treatment. It came in the form of a birth certificate signed by the then Minister Zola Skweyiya. In it, he made an undertaking that Batubele would live up to her name. But as we speak, currently, Batubele would be a teenager. But sadly, she seems to be suffering from lack of oxygen. Registered members, I urge our registered members to please familiarize themselves with the ethical rules that are on our website and make sure they treat our people with the utmost of respect.
Thank you very much, Mr. Damoda from the Healthcare Professionals Council. We'll visit this discussion. Next time we'll be talking about bogus doctors on this show, and I'm going to bring all three of you again to come and discuss this show. Dr. Trevor Majoro, thank you one more time for gracing our studios. And for the first time on this show, Dr. Howard Mayonga, thank you very much for the good work that you're doing, and good luck in the many other things, some of them very challenging that you're involved with. Thank you very much for this morning. One is Monati Auputelu Kubo. We'll run back next Saturday with another interactive show here on SABC Studio. Don't miss it at 8:30 in the morning. Thanks for joining us today. And for me, Dr. Victor Ramathesele, you take care.